Hi, Shruti. It is still the same. Hi, Navsheen. Hi, Vishwa. Nice to meet you as well. Hi, Shima. So many names I remember from our few hours back when we had some, interaction on the WhatsApp. Hi, Alale. So I remember names. Shima, you were there. And yes, Jatinder was there. I remember so many names now, but I'll get used to in the internal classes more. Hi, Josephine. Hi, Darshan. Hi, Aman. Good to see you too. Hi, Gaurav. Happy to see you as well, Alali. So, guys, as you all know, I have been talking about this from quite some days now that we are going to be having a very important class today. This is our radiology series. And if you have been following our work, if you have enrolled with us, whether for a dual course in the previous batch or for March 27 batch or for September 26 batch, so if you have been interacting with my page, either through just the public classes, free mentorship course, or anyways, if you have been interacting with me, my team, and Winspert, you know that we always constantly have been bringing some really exciting series for you all, which are completely ADC relevant series. And you all know that we have completed our TG4 classes word for word in the last 2 months from in the month of January and February. We did it for the March batch, and they're all available to our September batch candidates now. They have been doing it now. They have enrolled early. The course is officially going to start in April, but we have our September 26th batch completely active, momentum building up, and so much action. I see it happening every day. There are questions that you guys are discussing and questions that you're asking me on DMs. My DMs are already full. So there's no breather, and I love it like that. I do not need that. Let's keep the questions and doubts coming in. I do not want you to stop. I am seeing a lot of you enrolled candidates are also booking inner circle calls, which is amazing, by the way, because this is exactly the time you need your first inner circle call. So if you haven't booked already, please go after this class, drop me a message. And if you're enrolled with us, please get your first inner circle call with our mentors. That is the most important customized way of developing the strategies and plans around the Winspert study plan. And it will give you a great head start and a very strategic planning for your complete preparation. So that's number one. And today, as I also talked about this in our previous ebook blueprint class, where I showed you the ADC blueprint changes. And as you all are aware now, give me a yes if you are aware and give me a no if you weren't aware of this fact. So radiology percentage and the number of questions in the exam have increased and doubled up from 5% to 10% from the previous blueprint to the in the new blueprint. So if you did not know, please write no so that you can acknowledge now that you know it. And if you did know, please write down yes, because it helps us see that no matter how many times I come and take sessions and repeat the same things, people still miss out on information. So it's good now to acknowledge it. And if you did not know, this is your moment to learn that in ADC blueprint, it has gone from 5% to 10%. And that requires strategy. That doesn't require ignorance. And at Winspert, we brought the X-ray mocks even before the blueprint published it. How? Because every time with each exam, I have been observing the trends and creating and evolving the curriculum based on that. So, because of the studying of the trends and because Winspert evolves with each exam, other programs that you'll join will be static, will be completely running on the same complete plan that they have been running for years. At Winspert, you will only get an absolute evolving dynamic program that grows and evolves with every exam. It is not static. And yes, It keeps our students also on toes, and they have to also study the updates sometimes last minutes. But this is how they go to the exam, absolutely accurately, completely prepared based on the recent standards. Same thing happened in the exam March 26 also. All the TG4 new questions came, and our candidates were able to face them confidently from TG4 as well as for radiology. Why? Because our winning edge Q banks, our UAF, MMF, and our specialized Winspert X-ray mocks, they prepared our candidates so well that nothing felt new, challenging, or extremely complicated to them. That is the confidence that Winspert provides you. The preparation, this most updated program, and not one size fit all kind of strategy is not what we follow at Winspert. We give you personalized calls, we give you specialized mocks, we bring about newer articles, newer updates. Even if it's 1 week before exam and a new article comes up, I will update you. You will go to the examination with most contemporary updated information and mark every question with accuracy and confidence. That's my promise to you at Winspert. So, to continue the same legacy, we are bringing you a radiology series. This is going to help you, first of all, address this huge change in the ADC exam style, which is doubling of the radiology questions. And that is why this series is going to be 3 parts at least. This is what I'm predicting, depending on how it goes today. And I'll also understand how much of the speed and, the time that it takes. But it will be at least 3 part series where I will be encompassing the entire radiology syllabus for ADC in the coming weeks. Imagine if you are doing this at the beginning, what all you would be learning and doing while we get completely into the action of the plan in the middle of the program, right? If this is what you are doing in the beginning. So how the middle is going to be, how the end is going to be, and how the examination experience is going to be. Today, you're just getting a gist of that. And I am going to bring such amazing classes for you where we're going to have fun learning. I cannot promise you the world, but I can promise you one thing in my classes. I will never make them boring for you. I'll always keep them fun for you. When you come, when you look forward to a Winspert class, it would be through joy, with joy. We use joy as our compass at Winspert. We are working in the back end also on evolving the program for September 26. A lot of updations we are making on the study plan. And yeah, so as TG4 is covered, ICG latest is covered, word by word, everything is covered. Now my focus is other important ADC relevant series. So this is my first offer to you. After this one, I will be bringing another important series. After this series, there is a very special gift for entire ADC community. We will bring a very valuable, just dedicated X-ray mock for the ADC community once we finish this entire series. So today also I have few questions for you all. I hope we make it to the end and it doesn't get too stretched out, because I want to give you complete understanding of the concepts, but yet also finish it. I hope I have not over kept the syllabus for today's class. So let's explore it. But stay till the end. If we get to the end, we are going to also practice some questions. Now for today's series, today's part, I will start with the basics and build your concepts. So although we are doing an entire radiology subject in 3 parts or 4 parts, I want to still keep it a graduating way of learning. That is how we do it at Winspert. We graduate, slowly build the basics, and then go to the advanced concepts. So everybody ready to learn that with me from the basics to the advanced? So today I'll take you through the normal anatomical structures and then OPG errors. Both are extremely important for the exam. Normal anatomical structures keep getting asked. I will show you the X-ray and I'll tell you this has come in exam. I'll show you the error and I'll tell you this was in the exam. Okay? So I hope everyone's ready. All right. And before I start, there is also very important announcement. In few days, we are bringing a very, very, very never seen before kind of special mock, right? So this is going to be for all the candidates, new ones, those who are enrolled or even not enrolled ones. So are there any who are not enrolled with us? Can you just write yes on the chat so I know who all are here who are not yet enrolled with Winspert? So there's a special gift that we are bringing for entire ADC community now, and it's a very special one of its kind mock, never seen before. We are bringing a baseline mock, and that comes from my own experience of preparing. There's a very small story if I don't take a lot of time, but in 30 seconds I might try to cover it. When I started preparing, I wanted to have one mock experience where I know where I stand, what's my baseline level, and then I planned that for every MCQ file or resource I will achieve 95% before I go to exam. And that is what I teach the same in my course as well. So I want to give you the same experience of baseline mock, and it will be released for the entire ADC community in the coming week. And we will be announcing it soon, but you will have to register for it. So my team will be sharing the information. Please drop your comments and join our group if you haven't yet, because that's where the details will be shared. And this baseline mock is extremely crucial for you to understand where you're starting. And then I can take you to that 95% level before exam, so you can pass the exam in your first attempt with best scores possible, right? So my team would be sharing the details in a while. You can join our group and get the information on our very special baseline mock. It would be from mostly all the ADC subject, all the disciplines. It will prepare, it will test you in your initial basic knowledge, and then on based on this knowledge you will be building upon it. So it's a great head start, and you will get an explanation class for the same as well. All right, so let's start with our radiology series part 1. This is going to be covering the entire radio that is required for ADC. And please stick till the end. I will try the speed of the class. I'll try to keep moderate. If I'm going too fast, you can slow me down. Okay, but as you can see, I have 63 slides for you to cover. I will try to keep it crisp, informative, and still make sure that everybody's understanding. So pace will be a little bit moderate, not very slow. I'll keep asking you yes and no's in the middle and in between as well. So keep giving me yeses if it's making sense. Is everyone ready? Shall I start? Would you give me big yeses along the way so I know I'm not going too fast? And if you want any repeat, I'll repeat it one more time. Or if you want me to slow down, I'll slow down as well. But there's a lot we have to do today and in the coming classes, and it's an entire subject I'm covering for you. So let's make it happen. So today I'm focusing on the anatomical landmarks on radiographs and then the OPG errors. Why we are starting here? Because this is the basics. This is the easiest to grasp. And before you start identifying caries on x-rays, or before you start identifying perio disease, tumors and cysts on x-rays, I think what makes sense is everybody should be aware of how the normal anatomical structures look like. Because if you cannot know what healthy looks like, how will you identify how disease looks like? Does that make sense? Like, you need to know the normal anatomical appearance, otherwise you cannot tell if this is normal or this is diseased, right? That is number one reason. Another even more important reason is that ADC gives you normal anatomical structure questions on exam. There have been in the last year so many normal anatomical landmarks being asked. As I'll walk you through them, I'll tell you which one have already made their way into the examination, and then rest of them can only follow. So we'll start with how naturally your teeth look like, your natural enamel structure, your dentine, your pulp, cementum, your root tissues, your alveolar bone, and some restorations. Because if you want to identify caries, if you want to identify any changes in the bone or roots, you resorption, periapical area, you need to know that how your natural tooth looks like. So basically, the enamel being the most mineralized component and the hardest structure is the most radio opaque structure. And then on the root level, you also have cementum and dentine, but because of the mineral structure similar, there is not much difference in the radio density of cementum and dentine, and sometimes you will not be, most of the times you'll not be able to demarcate between the cementum and the dentine, but enamel and dentine very well. And this demarcation and this clear observation of radio opacity and difference in the radio density and then pulp will help you learning, observing the caries on your enamel as well as dentine. Does that make sense? Now this radiolucency in the center is your pulp. Now sometimes when the teeth can be normal, there will be no caries present on it. There can be some artifacts present, a radiolucent band or shadows on your cervical area of the teeth, right? Can you appreciate that here? And this is your cervical burnout caused by overexposure of the lateral portion of the teeth, and because of the difference of the radiodensity between the enamel and alveolar crest. Can you appreciate that? Now that can be misunderstood as your caries, but it is not. It is an artifact, and this is a very, very favorite ADC question. Cervical burnout. They will give you there. You will find no radiolucency, and the most important indicator would be that they would be present on the multiple teeth, and the reason is because of the difference in the radiodensity of enamel and your alveolar crest. And when you inspect closely, what you'll also observe is that the outer structure is still intact. So this radiolucency is not cavitation, it's not caries, but if you see it here, the outer structure of the root cementum is intact. So that's also your tell sign that this is your intact proximal surface rather than being caries. So this is a phenomena known as your cervical burnout. Does that make sense for everyone? Would you be able to now tell between the caries and cervical burnout? It is more like a diffuse radiolucency. Caries is mostly well defined. Caries, I'll show you in the next class. We'll talk about cariology, caries radiology, and then we'll also talk about IOPA and bite wing errors in the next part. And then I'll show you every caries level on the enamel, on the dentine, middle part of the dentine, 1/3 of the dentine to that levels. And clinically, when radiologically you find a certain caries, clinically how you classify it into C1, C2, C3, C4, and C5, and what should be the management plan, C0 C5. Yes, Mubaraka. So are you excited for the next class also when you learn about all the caries levels clinically as well as radiographically, and alongside I'll teach you the management also. So the entire SBQ gets prepared at once. Okay, wonderful. So this is your cervical burnout. It's different from caries one. The external surface is intact and it is more diffuse and ill-defined. Your caries is more well-defined and has a shape and certain very sharp margins compared to diffuse radiolucency of your cervical burnout. IGDAS classification, Smith, is just your clinical classification, what you find from visual and probing, cavitation or changes in the dentine colors, etc. IGDAS is a clinical classification. C0 to C5 is your radiographic classification. So when you completely mark a management, it combines IGDAS and Evans. Understood? Is that clear for everyone? Another important structure which will help you analyze the periapical diseases, endodontic diseases, is your lamina dura. I hope everyone can appreciate it here. This thin radio opaque layer lining the socket of the tooth. You can also appreciate here this. It is basically the cortical bone of lining the alveolar bone, right? It's a thin radio opaque layer of bone around the teeth. It's a cortical bone, right? It's a dense bone that bounds the teeth socket, and it has extremely important diagnostic value. So for a lot of your x-rays, you will be also assessing the lamina dura, whether it's intact or resorbed. And even in healthy teeth, sometimes lamina dura can have variable appearances, right? It can even be absent in certain teeth because of the angulation, but that is why you may also have to clinically correlate with the clinical signs and symptoms, right? But when you see an intact lamina dura, it suggests strongly that it's a healthy, vital pulp. Can everybody tell here? And now this is also a question in exam. Similar SBQ has been provided in exam. Same X-ray was given and a pointers were given in the exam and was asked, what is this white lining surrounding the tooth? So many of you who have taken the exam before can vouch for this. This is an actual exam question. So do not think that the basics are just for your build up and knowledge. No, they are actual practical examination questions. So alveolar bone comprises of cancellous bone, right? And your cortical plates, right? So your maxilla and mandible comprises of your cortical lining as well as your cancellous bone. So this radio opaque structure is the cortical lining, lamellar bone, right? But this comes in exam, right? It comes in exam, and a lot of people may remember it from the undergrad years, but a lot of people require the brush up, right? So that is why we will be covering all of them, but this is an actual examination question. Then comes your alveolar crest. It would be helpful for you to identifying the periodontitis. Alveolar crest levels are extremely important in terms of your identification of periodontal disease. Do you all agree with that? Give me yes and no's if you understand the relevance and importance of knowing the healthy levels of the alveolar bone. It should be normally within the range of 1.5 mm from the CEJ, not more than that. If it's gone below than that, that means there is recession and bone loss, and that would indicate periodontal disease, right? So these are your cortical borders of your alveolar bone. Again, it is in continuation with the lamina dura. When the resorption begins, it begins on the interdental crest of the bone, and then it recedes down. Clear for everyone? Yes or no's, please? So far, so good. Then comes our PDL space. Now, PDL space is the space between the tooth, the cementum, and the lamina dura, right? So that's your periodontal ligament space, which appears as a radiolucent band here. Can you appreciate this dark radiolucent band here? Pointers. Again, these are actual examination questions. And why ADC emphasizes on them? For the same reason. When you can't appreciate health, you can't appreciate disease. Your mind only, so your eyes will only see what your mind knows, right? If your mind doesn't know what healthy tooth structure looks like, your eyes will not be able to identify the disease structure in the exam. And no matter how basic it may be, seem when in examination you're exposed to various x-rays, sometimes it can get tricky to identify. Okay? So practicing and looking at it and giving a concept to your mind will train your eyes to identify it in the examination better. Does that make sense? So PDL space is a radiolucent band. Now it can widen where there is some kind of inflammation present, right? So it widens around the tooth when there is some kind of inflammation present. In periapical disease also, you can see PDL widening in the periapical area. Then intermaxillary suture, actually asked in the ADC exam. This has been also asked in exam. Can you appreciate this radiolucency, which is the fusion of your premaxilla? So it is your fusion of your premaxilla. This radiolucent band is your intermaxillary suture. It is in the midline of the maxilla, in between your central incisors. And it can terminate on the crest of the bone as a V-shaped or a rounded crest. I also want you to appreciate it that it is not bone loss. Sometimes your suture can terminate as a Y-shaped or a rounded shaped crest, right? So this is not bone loss, but rather the fusion of these two premaxillary bones. This is your narrow radiolucent suture, terminates on the crest as a small rounded or V-shaped enlargement. Then comes your anterior nasal spine. Now this is a radio opacity. Now a lot of radio opaque structures, X-rays are provided in exam, right? Radio opaque structures can be present. Your compound odontomas can be present here, right? Which will be radio opaque. Root fragments can be present here, which would be radio opaque. And now this is a normal anatomical structure, which is also radio opaque. So which is your anterior nasal spine. It is so your compound odontoma would be very dense, tooth-like radiodensity, and will be surrounded by like a pedial structure, right? And a cortical bone. Similarly, root fragment will also have lamina dura around it. But this one is a diffuse radiopacity. Can you all appreciate that? Please tell me. This is not a well demarcated radiopacity. This is a diffuse radiopacity far below the apices of the central incisors. And this is your radiopacity of the anterior nasal spine. Opaque V-shaped projection coming from the floor of the nasal aperture present in the midline. Okay, but I'm just saying the radiopacity in this area can be a compound odontoma. ADC is kind of favorite child these days, and also root remnants. Okay. Comes your nasal aperture. So this is your floor of the nasal cavity. This radiopacity lines that you're seeing, they are your floor of the nasal cavity, which is a radio opaque line. Can you all appreciate? Anterior floor of the nasal aperture. And this radiolucency, the darkness, is the aperture. So this is the floor of the nasal cavity. Inside the radiolucency is your nasal cavities, right? And in between is your nasal septum and anterior nasal spine, which is again triangular projection. This is your floor of the nasal aperture. So this is the floor. This radio opaque line is the floor of your nasal aperture. Aperture means a cavity, so in between it will be all radiolucent. But this radio opaque line, yes, the aperture is lucent, but the aperture lining is radio opaque lining, Shruti. Right? So it's the floor of the aperture, and the aperture itself is a void. It's a cavity, right? Airspace. So that will appear radiolucent. Does that make sense for everyone? The difference between the two? The aperture itself will be, of course, radiolucent. It's air cavity. And the floor of the nasal aperture or nasal cavity, floor is bony. Aperture itself is air cavity cushy. So that's going to be radiolucent. Does that make sense? Yes or no, please? Perfect, Mehul. Agreed? So the floor is radio opaque because of the lining of the bone, and the aperture itself is air cavity. So that's why it appears radiolucent. Perfect. Now comes your incisive foramen. Now, incisive foramen, also known as your nasopalatine foramen, anterior palatine foramen, the ADC exam can give you multiple options, and it's important to differentiate then your perioapical radiolucencies. When I taught you ANS, anterior nasal spine, I told you certain radiopacities which would be distinct from the diffuse radiopacity of the nasal spine. Now, this is also a diffuse radiolucency, which should be differentiated by the other periapical radiolucencies. Now, this is a very important site for developmental cysts and periapical cysts as well, the infected cysts, right? So odontogenic cysts could be developmental or could be coming from your infections. So it could be a site of an infected central incisors, periapical cyst, or your developmental cysts, but those would have rather far more defined borders. And this is a far more diffuse radiolucency. Can you appreciate now this complete ovoid diffuse radiolucency, now under which you can see the trabeculation of the bone? Can you all please write down yes if you can appreciate the nuances and the trabeculation of the bone underneath this radiolucency? Now that's your most important tell, that it is not a pathological radiolucency, but it's a healthy bone, and the foramen appears as an ovoid radiolucency over it between central incisors. It is diffuse but within normal limits, and you can appreciate normal lamina dura, normal PDL width, discontinued and separated from your diffuse radiolucency. If it's pathological, if it's coming as a periapical cyst, it will be in continuation with the lamina dura, right? But this is separate. Compound odontoma will have a bony crypt, Diana, right? Would be very well defined. It will have its own surrounding PDL-like structure also. And ANS is definitely diffuse radiopacity. Compound odontoma even has enamel dentine-like differentiating tissues, because compound odontoma has very structured dentinal and enamel resembling, original tooth tissue resembling tissues, right? Complex odontoma is haphazard, and it's intermixed of radiolucencies and radiodensities, right, Dinah? I will talk about it in the next class. Do not worry. Okay? I'll take you there one step at a time. So far, so good. Incisive foramen makes sense for everyone. All good. Perfectly clear. It's a diffuse radiolucency. Now, you have to learn that you have to differentiate from your developmental incisive canal cyst, which is also present here in the center, and which is also not connected with the adjacent teeth, because that develops in the incisive foramen itself, right? But how will you tell between the incisive canal cyst versus incisive foramen? Two factors. ADC can ask you this question easily. First, that the width of the foramen, if it exceeds 1 centimeter, you must suspect and investigate for the incisive foramen cyst. Number one, give me big yes if you're remembering these points. If the width exceeds 1 centimeters, you will suspect it for incisive canal cyst. If enlargement can be demonstrated on successive radiographs, so put them on monitoring. If originally it was big and you are checking it on successive radiographs, it expanding and enlarging, that further confirms it's a cyst and not your natural anatomical structure. Does that make complete sense for each one of you? Then comes our lateral fossa, which is also called your incisive fossa. Now, in between the central incisors was incisive foramen, whereas on the laterals, a depression on the alveolar bone is seen, which is called incisive fossa. It is a gentle depression in the maxilla near the apex of the lateral incisor, location-wise, okay? And the periapical projections, they are also similar to your diffuse radiolucency. Can you all appreciate again? It is also on the periapical area, and that is why I told you this is so important, because this is where your pathologies will be. This is exactly where normal anatomical structures will be. If you do not know how to tell between the two, you can easily be tricked in exam. Tell me, is it possible or not? If I don't teach you these are the natural structures, in exam, you will go and you'll be like, oh, there was a periapical radiolucency. I chose it's a non-vital tooth. Why? We should know that in maxilla on the lateral incisor, there's also a structure which is healthy, normal anatomical variant called lateral fossa. Again, you can appreciate it by the fact that trabeculation is intact. Trabeculation is entirely intact. Lamina dura is entirely intact. Can you please appreciate that beautiful lamina dura and beautiful trabeculation throughout? And your your eyes can only see what your mind knows. If your mind doesn't understand or knows anything, your eyes will not see it even if it's lying in front of you. Can you appreciate and know that? Please, that's crucial for any X-ray question. You are relying completely on your eyesight, and your eyes will only detect what your mind understands. Otherwise, something lying in front of you, if your mind cannot appreciate and understand it, will not receive it. Even if it's in front of you, even if it's out there, your mind has to know first. Your eyes only see what your mind knows. Remember this and never forget this, and you'll never go wrong with your X-ray questions. Trabeculation rhythmic. Cancellous bone has trabeculas. Remember, cancellous bone has trabeculation, and cortical bone has lamellars. Remember, in radiology, the anatomy, the first year we read that. Yes, that's how far I can take you. So lateral fossa again is a natural structure present here on the bone. And how will you tell? Because of the trabeculation, intact lamina dura, and any other absence of clinical symptoms will suggest that it is a normalcy of the bone and not the pathology. Then comes our nose. So it has a uniform, slight, opaque shadow here. Can you appreciate the nose shadow? It's a soft tissue, but it gives you a slight, opaque, sharp border shadow. Can you appreciate this rounded shadow here, everyone? Now, this slight radiopaque shadow on the incisors is a soft tissue outline of the nose. Again, no pathology. It's a normal anatomical structure, and ADC has asked you this one. In the last year examination, this has been asked. Now, again, a very important structure that you need to know and understand is your maxillary sinus. Now, sinus is again like your nasal aperture, radiolucency lined by your radiopaque floor of the cavity. Similarly, for your sinus, it's a radiolucency, but the floor of the sinus is lined by your delicate radioopaque line, which is again a cortical bone. Radiopaque line, because alveolar bone is lined by the cortical bone, which is lamellar bone, and inside is the cancellous bone, right? Erica, did you ask about that one? That soft tissue shadow is the nose tip shadow. This is the nose tip shadow, the soft tissue shadow. Okay. Now this delicate radiopaque line is again the cortical bone, because ADC can ask you, is it cancellous bone lining or it's a cortical bone lining? Tell me, what is a lamellar bone? It's a cortical bone lining of the alveolar bone, right? Agreed? And inside is the cancellous bone, which is your trabeculated bone. Now maxilla has more cancellous bone than mandible. We all know that, percentage wise. And thicker cortical bone. Mandible has thicker cortical bone, right? Perfect. That's important implant question. D1, D2, D3 types. Remember? Connect the dots always as you move along. It helps you remember other things also. Now, sometimes this floor of the sinus will be confluent with the floor of the nose. So floor of the nose also has a radiopaque line. Floor of the sinus also has a radiopaque line, and sometimes they meet, and when they meet, they create an inverted Y anatomical structure. Can you appreciate it here? In this X-ray, inverted Y, this is the floor of the nose, this is the floor of the sinus, and when they meet, you see this inverted Y structure. This is again a very important anatomical finding asked in the exam. This is again another example of sinus lining, right? Again, sometimes it can be completely when teeth are extracted, the pneumatization can increase, and see this cortical lining has almost completely merged with the cortical level of the alveolar bone, right? So it extends towards the crest of the alveolar ridge, and there is no cancellous bone in between, very thin lining. Completely not ideal situation for implants because implants would need thicker cortical and some cancellous bone to retain. Then comes this zygomatic process in zygomatic bone. Can you appreciate this radio opacity? Here also, along the under the apices of the maxillary molars. This is a U-shaped radio opaque structure. It is known as your zygomatic process of the maxilla, and it merges with the zygomatic arch. It is a radio opaque line. U-shaped radio opaque line is your zygomatic process. It merges anteriorly with the zygomatic arch, right? Pterygoid plates, sometimes they may be visible, sometimes on posterior IOPAs they may not be visible. If your IOPAs are covering the areas behind the tuberosity, you can see the pterygoid plates. Can you see that? This radio opacity is your pterygoid plate, and there, this is where your tuberosity terminates. This is where your maxilla terminates, and this is the external extension of pterygoid plates. They may not always be present. Sometimes it could be. Here also it's present. Can you all tell me before I teach you, can you all appreciate what this little thing doing here? What is this little pokey thing? Can you tell me, some of you? Absolutely correct, Zeba. This is your coronoid process, making it slight, what do you call that? Photobombing? Yes. So this is our little coronoid process, photobombing our maxillary IOPA. Now this is your mandibular structures. This is what? A fractured mandible? What do you think? Is this what? A fractured mandible? A cleft? What kind of cleft? This is symphysis. This is a natural anatomical versions find till in the first year of life before fusion pavan. Yes, only before the first birthday you'd find it. It fuses around the age of 1, and it completely is the symphysis. It will not be observed on any x-rays after the age of 1. It fuses by that time. It is a radiolucent line in the midline of the jaw, and you will see you're forming deciduous teeth. These teeth buds are not permanent teeth buds, but rather, so some central, primary centrals have erupted around the age of 6 or 7, right? 6 or 7 months. And at that time, it will still be not fused. Agreed? Do we all agree with that? Around at the age of 6 to 7 months, mandibular incisors may pop out. Other incisors are still forming. Canine as well. These are all primary teeth. Age is around 6 to 7 months, and that's why you see it non-fused. Wonderful. Now, what is this one? This is your genial tubercle. Occlusal X-ray may not be asked, but this can pop up in your lower IOPAs. Mandibular lower IOPAs, it will be seen as a radio opaque mass, again diffused, not well demarcated. Underneath the bone trabeculation is also visible, right? So please know that this is not your sclerotic bony island or any bony change because of any chronic inflammation. This is not idiopathic osteosclerosis as well. This is a natural anatomical structure called genial tubercle, right? If sometimes the positioning of the film is too low, it can appear here. It is your genial tubercle. Then comes our mental fossa. So this is a depression on the labial aspect of the mandible. Just like we had lateral fossa here, mental fossa is also seen here. Can you all appreciate this? Again, diffuse radiolucency, right? But trabeculation intact, lamina dura intact, so no pathology. It's your natural anatomical structure. And here, can you appreciate this radio opacity around this small dot? What is this one? This is your lingual foramen. Can you appreciate this? This is your lingual foramen. Then comes our mental foramen. Mental foramen is what? It is the anterior limit of your inferior dental canal. Again, very commonly asked in exam. You can mistake it as a periapical cyst or periapical abscess in your premolars because it can sometimes be completely close to your mandibular roots apices. Again, the differentiating factors would be absence of any clinical symptoms, lamina dura completely intact, right? So this is your mental foramen seen near the apex of the second premolar. It is the anterior limit of your inferior alveolar canal. Can you all appreciate this canal here behind the foramen? There is also slight radio-opaque shadow here of the lamellar bone lining the inferior alveolar canal. Can you also appreciate that? See, these are the minutest details that you have to learn and start appreciating on the x-rays, because this is also a very common question now getting asked in exam of the risk of third molar extraction with inferior alveolar nerve injury. So what are the signs of inferior alveolar nerve injury? What are the indicators, the risk indicators that with the third molar extraction, the risk would be higher? That is why observing the inferior alveolar nerve canal is also extremely crucial. Now, this is your mandibular canal behind your mental foramen. It is lined by this lamellar bone. Sometimes this lamellar bone can be interrupted. That again doesn't mean that it is a pathology. And it can also show as a PDL widened around the tooth. Can you see that? Now that doesn't mean widened PDL because of pathology. This is just that the tooth is overlapping with the canal, superimposed on the canal. This is extremely important. Do I have everyone's attention here? So mandibular canal superimposed over the apex of the molar, causing the periodontal ligament space appearing widened. But you can appreciate an intact lamina dura. So disruption. This is the disruption of the canal lining, right? I will be taking another class on the inferior alveolar nerve injury risk factors because ADC is giving a lot of questions on that, and from the latest release papers, the concepts are also upgrading. We'll talk about that as well in coming classes. Then comes your mylohyoid ridge and external oblique ridge. Do you all know that ADC has been asking this question constantly in the last year also? Identifying mylohyoid ridge and your external oblique ridge. So mylohyoid ridge lies under the apices of the molar and external oblique ridge lies around the CEJ of the molar. Can you learn that? Can you memorize that? External oblique ridge is on the around the CEJ of the third molar and your mylohyoid ridge is around the apices. That is the differentiating factor. It's again also thickened cortical bone, right? So it is a corticated bone, dense radio-opaque line seen around the roots, and external oblique ridge is merges with the CEJ. Then, yes, mylohyoid ridge is also known as internal oblique ridge cushy. Okay? Then comes your submandibular gland fossa. This is a diffuse radiolucency which is not marked by any corticated bone. It is also a depression where your submandibular salivary gland is located. It is a concavity in the bone, so looks as a diffuse radiolucency, just like your lateral fossa, your mental fossa, right? Which part, Samina? And this is your submandibular fossa. You want me to tell you the This is your mylohyoid ridge. A radio-opaque line along the apices of the molars is your mylohyoid ridge, also known as your internal oblique ridge. Very favorite ADC question, Samina. An external oblique ridge comes on the top crest of the alveolar bone, merging with the CEJ of the third molar. So ADC will give you these two radio-opaque lines and give you arrows on one and will ask you what is the structure. So if it points to this top one, that's your external oblique ridge. If it points to this bottom one, this is your mylohyoid ridge, also known as internal oblique ridge. Thank you. Wonderful. Now, this is your submandibular gland fossa. Submandibular gland fossa, right, is a diffuse radiolucency. Again, trabeculation will be there. It's a depression where the salivary gland, submandibular salivary gland is located. Now, this is also a site for Staphy's defect. What is the difference between Staphy's defect and submandibular gland? Can anyone tell? Staphy's defect is an ectopic gland, not normally present there inside the bone. Whereas your submandibular gland fossa is a normal depression for your submandibular gland. So can anyone tell how do you differentiate Staphy's defect? Location is same. Traumatic cyst, Staphy's defect, and submandibular fossa. 3 radiolucencies, same location. What is the differentiating factor? Staphy's defect is corticated. Number 1. It's always corticated. Very clear-cut, demarcated, corticated radiolucency. Will you remember that, please, everyone? Submandibular gland fossa, diffuse radiolucency. Absolutely correct, Zoom. Staphy's defect is below the inferior alveolar nerve canal. And your traumatic cyst, what is the pathognomonic sign of traumatic cyst? Just giving you a hint here. Scalloping appearance around the roots of the teeth. So radiolucency will spread in the roots of the teeth. Now this is your external oblique ridge. If there was a third molar here, you would see it merging with the CEJ of that. Right? Can you appreciate external oblique ridge? Sometimes on some IOPAs, you see this radio opacity in the bottom. What would that be? It's your inferior border of the mandible. Inferior border of the mandible, inferior cortex of the mandible. And now this again, pokey structure, coronoid process, little friend, we saw in the previous x-ray. Here to say hi again. Can you appreciate this one? Yes. Now, certain restorative materials can also be Safura. When I talk about the defects in the upcoming classes, I'll show the Staphy's and traumatic cyst when we talk about the cysts and the lesions, right? Because today it was just normal anatomical structure, so there's not the x-ray of that. But Staphy's defect, it's not a pathology also, but it's also not a structure, not normal anatomy. So it will come with the other findings. So now some restorative materials, these are amalgam restorations, completely radio-opaque, even denser than your enamel. These are your cast gold crowns, even more radio-opaque, denser than your enamel. Can you appreciate pins here? Because you could be given cracked teeth questions and pins can also be seen, and then you would be asked the reason for the cracks, the reason for the sensitivity, the reason for the perforations. So learn to look closely. Train your mind so your eyes can start seeing things. These are your restorative root canal fillings. The GP is less radiodense than your silver points. Silver points are not used commonly. GPs are usually seen and radio opaque GPs are available. Gutta-perchas are available. Now, restorative materials, some composites are radiolucent, and these are the bases. Can you appreciate the radio opaque base under the composite here? Can you all appreciate? So these are your silicate restorations, which are radiolucent, but the base is radiopaque. Sometimes it could have some medium radio density. Wait a second. Right? But how you can differentiate from the cavity from the caries is caries would have triangular appearance, right? And your composites have well demarcated, prepared tooth appearance, box shaped cavity. Now, these days, even radio opaque composites are available. Now, these are your stainless steel crowns and your orthodontic appliances. And that was your normal anatomical structures and your restorations. And in the coming part, I will now train you for identifying caries and periapical diseases, all of that. So once you understand the normal anatomy, it would get easier and immediately you'll start identifying diseases. Is that right or wrong? Tell me now. Can you even understand and get to that understanding that how, if I understand a healthy looking x-ray, I can immediately start identifying disease. That's your job in exam. Now let's do the OPG errors. So OPG errors can be two types. It would divide it into patient positioning errors and technical errors, right? So first we'll talk about the patient positioning errors, because when you are taking an OPG, you have to instruct a patient to stand a certain way. They don't be slouching, they don't be biting too anteriorly. There is a perfect notch given to put the teeth on. They can sometimes bite ahead of the notch towards the x-ray. Then they can bite sometimes behind the notches, farther from the x-ray source. How will it affect and look on the OPG? You must learn. ADC loves giving OPG error questions. So tooth, when they are too anterior or the patient is too far forward and bites in the front of the notches, right? They will appear narrow and blurred. So let's how it will look on an OPG. The teeth will appear narrow and blurry. They will lose their resolution. They will be less sharp and narrow. So closer is narrow. Remember CN and FW. Farther is wider. Closer is narrow. Can you memorize this concept? Farther is wider, closer is narrow. CNFW. Can you remember this mnemonic? CNFW. That's how you will always remember. If something appears narrower on X-ray, it is closer to the source of the X-ray. If something appears wider on the X-ray, it became farther to the source of the X-ray. Very simple. FWCN. Yeah, where? CN, closer will appear narrower. Farther from the source you go, it will become wider. So teeth here are closer to the X-ray. That's why they are appearing narrower. Can you appreciate here, please? Yavar? Just have a look. Can you appreciate how centrals are looking narrower? Anteriors will get narrower. That means patient is biting forward. When they're biting too posterior or too far backward, so farther will appear wider. Can you appreciate here? FW. Farther will become wider. Can you appreciate here? Farther has become wider and blurry. Blurry and wider. And closer is narrower. Is that clear for everyone? Farther is wider, closer is narrower. Yavar, clear for you as well? Then the patient head is not centered and it's turned. Well, when the patient turns to one side, what does that mean? Blurry will be in both the cases. Yes, Javed. So when the patient turns to one side, what does it mean? He gets closer to one side and farther to the other. Yes or no, please, quickly if you understand that. If he turns his head, he gets closer to one side and farther to the other side. So that means you can easily tell which side he turned on, because where it appears narrower, that is where he turned, because that became closer. And where the opposite side will appear wider. Yes or no, please? Is it making sense? Easy peasy or no? So FWCN. So now here see the right side of the ramus is so wide and left side of the ramus is so narrow. Where did he turn? He turned left because CN FW. Farther is wider, closer is narrower. Now here right is narrow and left is wider. Can you appreciate that? Even the teeth look narrower here and wider on the left side. So where he turned here? To the right. CN, FW. Perfect? Easy peasy lemon squeezy? So now tell me, where did he turn? Where did he turn? Look at all the three and tell me. Right appears wider, left appears narrower. So he turned towards the left. Here, again, right is wider, right? Left is narrower. He turned left. And on the third one, left is wider, right is narrower. So he turned right. Right? That's beauty. Then head looking down, head looking up. When the patient tips only the chin to down, is an exaggerated smile. V-shaped mandible. So when the chin is down, exaggerated V-shaped smile. Can you appreciate it here? And when he looks up, the chin up, the smile becomes inverted or flat. So chin up, depending upon how up, either will become flat or will become reverse smile. Both are possible depending upon how much it was tilted up. Right? Because a natural slight smile curvature is always there. So even a flat plane would mean that he looked slightly up. Does that make sense? Because it's not always reverse smile. Looking up can be flat, plane also. Give me big yeses if you understand this nuance. Yes? So slightly up, flat, more up, reverse smile, and down, completely exaggerated smile. Perfect. I like that, Neil. That's how it should be. So this is a completely reverse smile, kinda like a flat base, but these are all head up. Agreed? Understood? Yes or no, please? It's like a frown, yes. Lead apron shadow can also show sometimes when the lead apron interferes and comes into the beam's path, and it will appear as a radio opacity with a very clearly well-defined margin. Thyroid collar should also not be worn when the OPG is taken. Lead apron should be placed low. It should not block off the primary beam. It would appear as this radio opaque, well demarcated line. Can you appreciate that, please? Now, cervical bone shadow. So spinal vertebra shadow can also be seen as a radio opacity, but it would be rather less radio opaque than your lead apron. It would be rather diffuse radio opacity. Under it, you will still see the teeth, whereas lead apron will completely mask the teeth. Can you appreciate this one? Very, very, very little detail and nuance here. Teeth are masked here. That's your complete radio opacity with your lead apron. In your spine shadow, the teeth are still visible. It's a relative radio opacity of another bone. When does that happen? The spine shadow comes when the patient is slouching, isn't straight. His spine is slouching, slumped or bent or slouching. Any of these three words could be given in the options, Ramona, right? And it will extend up through the middle of the film, up through the upper and lower, both the teeth, anterior teeth, cervical vertebrae shadow when he is not standing straight. Now this is your palatoglossal airspace. Again, ADC's favorite question. Do you see this radiolucent band on the apices of all the maxillary teeth? This is when the patient fails to place the tongue against the palate during the exposure, which he's advised to. When he fails to do that, palatoglossal airspace shows as a radiolucent band above the roots of maxillary teeth. And it masks the apices of the maxillary teeth, so makes the reading difficult. Then also the lip space can come when the patient does not close the lips also. This can appear as a radiolucent shadow of lip space. When tongue not positioned on the palate, you get palatoglossal airspace around the apices of the maxillary teeth, makes the reading difficult. And this one also is the lip space when the patient doesn't close the lip when biting on the notch. Ghost images, so commonly asked in exam. Now, number one thing to learn about ghost images, always on the opposite side, always magnified, always higher. Can you remember that? HOM, hom, higher, opposite, magnified. HOM, always higher, opposite, and magnified, right? So now these earrings, so this image is the ghost image of this one, and this opposite image is the ghost image of left earring. HOM, higher, opposite, and also magnified. Can you appreciate here the earring ghost shadows? This is the A earring and this is the ghost image. Higher, opposite, and magnified. Clear for everyone? Crystal clear. Always higher, opposite, magnified. Failure to remove certain objects. In this case, can you appreciate floating teeth? What is this? This is your acrylic denture. Ankita, these are given as questions in exam, ghost images. These are artifacts. So they can be mistaken as radiopacity or pathology. That is why you must know what the ghost images are. These are the artifacts. Right? Can you appreciate the floating teeth here when you forget to take out the dentures? Now, in this case, alveolar bone is completely visible because acrylic was radiolucent. Doesn't make reading difficult. But here, the metal-based RPD was left and the reading gets difficult because now all the bone levels are hidden. So this is your metal-based RPD. Always should be taken out. Glasses should also be taken out. Yashila, ghost images are harm, which means if the patient was wearing an earring on the left side, the earring's ghost image would be visible on the higher level, opposite, so right side, and magnified. Yashila, did you see that on the X-ray also? It's always on the opposite side. So if they label it, this label, they put a pointer here, suppose Yashila in exam, and they give you both earrings are wearing, and they will ask you this pointer is the ghost image of which earring, right or left? Tell me. This pointed image is the ghost image of which earring, right or left? If you don't know the home rule, you will not know. Ghost image is always present on the opposite side and on the higher level and on the magnified side. Understood? And this can be asked. So they can give you, so sometimes it can also be a ghost image of restoration also. Now this is the nose, this is the tongue ring, tongue piercing which was left, again masking the anterior teeth. So all the metallic jewelry should also be removed. Now this is what? Step defect. Can you appreciate? Looks like a fracture. But this is not a fractured bone. This is a step defect and this is a major patient movement. Shows like a break in the mandible. It's a major patient movement. This is major one. Sometimes it can be slight movement and it would look like this step defect. Can you appreciate it on the bottom red pointer? Step defect here, which can be mistaken and misrepresented as a fracture. These are your static electricity images. Sometimes when you take out the film from the box too quickly, it can create a static discharge, which upon development will look like a tree branch appearance. That's your static electricity appearance. This is your double exposure. It will be seen as when you expose the cassette from Arham, clinical findings. Clinical findings, absolutely. Fracture would have clinical findings and history of trauma, right? If a healthy patient, you take an OPG and you get this defect and there's no history of trauma or previous fracture injury, then it's definitely your patient movement defect. Okay? So when there is a reverse cassette, it can be blurry, incomplete, lack of contrast, and incomplete aberrant images. Underexposure would be light, overexposure would be dark. I will be taking about underexposure and darker exposures in the bite wing and IOP errors in the next class. This is double exposure. As you see, there are two images taken on the same cassette, on the same film. Double pictures. I will do the same one on bite wing and IOPAs also. Now let's practice certain questions now. Are you ready to identify the errors, to identify the normal anatomical structures? Are we all set to test what we learned today? Apply our knowledge? All right. So what is the cause of error? Now I will be also testing you on keywords and reading. So these are going to be tricky. Give your answers accordingly. What is the cause of the error which is seen in the apices of maxillary teeth shown in the given OPG? Right. Absolutely correct. What do you see here on the apices? It is the radiolucent band along the apices. So this is your palatoglossal airspace. And how does this happen? The cause is that patient failed to keep the tongue against the palate. Is that clear for everyone? Right? Now there is another slight fault, not too much, very, very slight fault. Is the sad or an exaggerated smile, Mubaraka? That is where you're getting tricked again. Slightly head down, not too much, but slightly. But now the trick is, question asks, what is the error seen in the apices of the maxilla? So even if it was chin down, but that doesn't affect the apices of the maxilla, the apices of the maxilla get affected by the patient failing to keep the tongue on the palate. Is that correct? So answer will become C. Another question, what error does the given image show? What error does the given image show? Mubaraka, everyone, what is the answer? So now that's where you're getting confused. The ADC exam always asks you what is the error and what is the cause of the error. They are two very distinct concepts. Mubaraka, C is wrong. What is the defect or what is the error and what is the cause of the error? Are they same things? And that's where the trick lies in ADC, and it gets you like that. It is not normal. Can you all see it slightly flat or reverse smile? And I told you that even slightly chin too high can make it either flat, and if it's too high, it would be completely reverse smile. This is not how flat occlusion plane should be. There should be a slight curvature. So error is flat occlusal plane, and the cause of the error, if it's asked, is then it's C. Chin up, Yes, Diana. No, the cause of the error was chin up. The error was flat occlusal plane, Diana. Can you all appreciate? The error is different, cause is different. Ditching versus creep. Remember the question? Anyone who's done the UF2 file with me last batch, ADC asked that question. What is the defect on amalgam? What is the cause of this defect? Ditching is the defect. Creep is the cause of the defect. Phenomena is called creep, which leads to the ditch, which is the defect. Same concept. What is the error? What is the cause of the error? What is the defect? What is the cause of the defect? And ADC loves tricking you like that. This is how we trickle down to the base and details of the questions. The cause of the error is chin up. Absolutely right, Diana. And this is exactly every single question in ADC tricks you. And at Winspert, I take you down to the quantum physics of ADC. I'd love to consider that we go to the quantum physics of ADC. Don't we? This is the quantum level where you understand what's the error, what's the cause of the error. You're looking into the complete question dissected keywords. Why not E? Because there is no as such cervical vertebra shadow. There is no. That will be Sanjana here. What is the cause of the error seen here? What is the cause of the error now? Everyone's paying attention to the error and the cause of the error? Give me yes or no's now that everybody is paying attention to those details. So is it a good nuance to learn on the first class of September 26 exam? Tell me. Can I tell you that? This is a very, very advanced level learning you're doing here. Those nuances, people take weeks to master. And I'm giving you away in the first class still. Spine isn't straight. The teeth are still visible. It is going up till the midline. Both maxillary and mandibular teeth involved. What would that be? The error is vertebra shadow on the teeth. That is the error, right? It is a cervical vertebra shadow, radiopacity, that's the error. But what is the cause of the error is slouching, slumping, not standing straight. Any of these words could be used. Answer will become A. No, there is a curvature. Absolutely right, Javier? It is a curvature. It's a normal curvature. Now, what one is this? Ha ha ha. Evil smile. Is it? Now, what is the error and what is the cause of the error? The error is A and the cause is D. Why are we saying B? Is it chin too high or chin too low? Exaggerated smile is chin too low. Right? So the error is exaggerated smile and cause of the error is patient's head tilted downwards. Clear now? Error is A, cause of the error is D. Beautiful. Ha ha ha. Good one, Rhythm. Now, what two white arrows are representing here? Two white arrows, two radio opacities. What are these? You got to tell me that. No hints coming along your way. Which one is the top one? Which one is the bottom one? The top one is mylohyoid ridge or internal oblique ridge. And the bottom part is the inferior cortex of the mandible. Is that right? That's the beauty. You guys were paying attention. So thank you really for your beautiful, wonderful attention. What an amazing class. Really? Great start to a great batch and a great session and a great series start. No other way to have it done any other way. Had fun? Most importantly, did you have fun or not? Was it boring and dull, or was it fun, exciting? Joy was our compass or not? Yay, thank you for that. And it was amazing fun doing it all with you and feeling blessed myself as well. Bhumika, thank you so much. Thank you, everyone. Beautiful days. Beautiful day. Blessed day. I miss you too, Fatima. Thank you, Samina. Thank you, Snigdha. Thank you, Zaiba. Session ended. We did it timely. I was like, whether we'll finish it or not.